Good afternoon and welcome to the Substance Use Disorder Echo Clinic. My name is Clement Chen and I'm a clinical pharmacist for the Northern New Jersey MAT Center of Excellence. I'll be facilitating and presenting the Echo session today. Also here with me today on our panel are my colleagues, Drs. Linda Baselli and Brian Colangelo. Dr. Linda Baselli is a board-certified addiction medicine specialist at Cooper University Healthcare, and Brian Colangelo is a licensed clinical social worker and is the lead behavioral health therapist also from Cooper. All are extremely passionate about the need to increase access to treatment for opioid use disorder, particularly amongst the underserved, and have tremendous experience in the integration of opioid use disorder management as a part of primary care practice. So Dr. Baselli, Brian, you'd like to wave a quick hello? That'd be great. Awesome. And I also want to introduce our Project Echo team, Sean Cudahy, Ruben Nanez, Amy Fisher, and Teresa Hughes. If you'd like to give a quick hello to everybody. Thank you so much for helping us with this session today. Please note this session is being recorded and will be available online after the session. If you are joining us today for the first time, Project Echo is a globally recognized educational program that builds learning communities to share expertise and problem-solve patient and client situations. We encourage you to change your screen name to display your name so we're able to know who you are. Please also put your organization in the chat so we can get to know one another. And if you have the availability to use video, please do so, as seeing your faces helps us better connect with each other. We would like to be as interactive as possible, so please ask your questions or offer your own recommendations at any time by using the raise your hand feature in the chat box or by entering your questions in the chat. We will do our best to address your questions and comments. Given the increased usage of Zoom around the world, we want to be sure that you feel comfortable within our community. So our purpose is to ensure a collaborative, safe space for our participants. And we appreciate you for keeping us this forum safe. As a reminder, since you have registered for this session, you do not need to register for the upcoming sessions. We encourage you to save the Zoom connection information and add it to your calendars if you have not done so already. We will share links to the presentation and recording for you to access later on our Northern New Jersey MAT Center of Excellence website. This series is approved for continuing education credits for the medical, nursing, pharmacy, and social work credits. In order to receive your credits, you must complete a post-session survey for each session you attend, and continuing education credits will be awarded at the conclusion of the series in December. We would love for you to submit your questions and present your patient scenarios during our sessions, so please look for a link to our question submission form that will be shared in the chat. And for those participants who present during the session, you are eligible to receive a $30 Amazon gift card for completion of the case presenter survey after your presentation. Also, as a thank you for regular participation, we are offering a $30 Amazon gift card incentive for completion of the 6-session survey. So remember, we're always to be HIPAA compliant. When you speak, please introduce yourself and be respectful and supportive of one another. And most importantly, please have fun and enjoy today's session. Today's presentation will be on managing benzodiazepine use disorder, particularly those who have been on it chronically and dependent on benzodiazepines, especially in those patients with opioid use disorder. So let's get this presentation started. All right, so the topic of today's presentation, as we discussed, is on chronic benzodiazepine use and the disorder in patients with opioid use disorder. I don't have any disclosures, so our learning objectives is to understand the epidemiology and prevalence of benzodiazepine use, as well as in patients with benzodiazepine use disorder, with a focus on those with opioid use disorder. We'll explain the mechanism of action of chronic benzodiazepine use and its association with dependence. We'll also look at the literature, looking at the outcomes of those patients, particularly with treatment retention and mortality amongst those who use benzodiazepines and those who are on medications for opioid use disorder. We'll understand some of the strategies helpful to assess and treat patients with these concurrent diseases. So looking at the background and epidemiology, I think the biggest thing we should think about is that people who misuse benzodiazepines, so they're not using benzodiazepines as prescribed, doesn't necessarily mean that they have a substance use disorder, or in this case, a benzodiazepine use disorder. There are countless patients who are dependent on benzodiazepines, but also may fit the criteria of needing to take benzodiazepines for a long time, perhaps because they've been on it already for a long time, and you need to perhaps taper them down due to risks of benzodiazepines. When we look at benzodiazepine use and misuse, just overall, this is a national survey on drug use and health in 2015 through 2016. We see that about 30.5 million adults use benzodiazepines. However, only about 5 million of those actually misuse benzodiazepines. And by misuse, again, we mean those who are not taking as prescribed, perhaps are using it more than directed. Only 10% of those, however, of those 5.2 million adults actually had benzodiazepine use disorder, broken down by benzodiazepine dependence and abuse. And if you look at some of these bullets on the right, really shows what are someone's individual level factors that lead someone who's misusing benzodiazepines and developing a benzodiazepine use disorder. So it's highly correlated with those who are younger users, who are male sex, for example, uninsured, a low family income, perhaps those who are unemployed, those who have ER visits, and of course, those who have concurrent mental health and substance use disorders, particularly those with opioid use disorder. So what's some of the rationales for benzodiazepine misuse? Just misuse in general, without thinking about opioid use disorder, most patients would misuse benzodiazepines to relax or relieve tension. However, in patients who have been diagnosed with a benzodiazepine use disorder, they're not really, their main motivation to misuse, I should say, benzodiazepine is more to help with emotions, or perhaps getting high or hooked, and perhaps also increasing or decreasing effects of other drugs. So here's a little difference in terms of people who have benzodiazepine use disorder and also misusing, and those who are misusing without benzodiazepine use disorder. And actually, as I go on in the presentation, I'll just refer to as benzodiazepines as benzos for short. And what about the rationale for combined use and prevalence in patients with opioid use disorder? In those who use benzos and also have opioid use disorder, they have significant amount of social determinants of health. Perhaps they live chaotic lives. Their family situations, they're really involved in lots of trauma or have lots of experiences with violence and trauma. All these can potentially lead to high levels of psychological distress, and another reason why people add their benzodiazepines on top of opioids, the medications for opioid use disorder. It can also be used to treat insomnia and sleep disturbances, to treat withdrawal of other substances such as alcohol withdrawal, which really provides even higher risk, especially if you're using two sedatives together. The treatment of protracted withdrawal, which is a high focus we really want to think about when we're treating patients with these chronic relapsing diseases of both opioid use disorder and benzodiazepine use disorder. Some patients may also use it for synergistic euphoric effects, but from our experience, most of the time, patients are using it for treating other particular conditions, as we see here in this slide. And in terms of patients with benzodiazepine use, the prevalence of benzodiazepine use in those who are on buprenorphine, the lifetime prevalence is actually 67%. And if you look at the current prevalence, you see that for the most part, most are not abusing the benzodiazepines, 6.5%. Most of them are dependent, 24.1%, and non-problematic use is about 15%. So when we look at co-occurring opioid use disorder with benzodiazepine misuse, what exposure, we want to look at what the exposure to opioid use disorder and what is its relationship with benzodiazepine use. So if you look at this quick chart, you look at this column right here with benzodiazepine use, in general, by having an opioid use disorder, whether it's heroin or prescription opioid use disorder, what's the likelihood of someone using benzodiazepines in general? there are much higher odds, as you can see, an increased likelihood of those of using benzos with opioid use disorders. Now, if you think about misusing, especially in those with benzodiazepine use, who are misusing with benzodiazepine use disorder, compared to the patients who use benzodiazepine use, therapeutically and as prescribed, there is so much greater odds or higher likelihood of misusing with, especially when they have a benzo use, much like higher likelihood of having a benzodiazepine use disorder. So now that we understand that there is a higher likelihood of benzodiazepine use disorder in patients with opioid use disorder, what are some of the overdoses involving benzos? This is a figure that looked at national drug overdose deaths from 1999 to 2019. And we see a steady increase in overdoses and overdose deaths, I should say, involving benzodiazepines. Some interesting facts I was able to find was that benzodiazepines are present in greater than 30% of overdoses involving opioids. And another way to also think about it is opioids are present in 75% of deaths involving benzodiazepines. So as you can see, the interplay between benzodiazepines and opioids use can really confer really high risk and risk for overdose deaths in patients, especially if they have an opioid use disorder. So what is the pharmacological basis for addiction? Why it's so difficult to stop benzodiazepines? On this little chart on this graph on the right, just looking at sedative hypnotic agents and how they work, they really has effects on the central nervous system. Depending on the dose, as you go up on the dose, you first experience sedation, then you experience hypnosis. Then with higher doses, you're experiencing respiratory depression and perhaps coma. That's what we really found with the use of barbiturates. With benzos, however, it did not really, patients with benzodiazepines did not experience respiratory depression or coma, especially if they only use it by itself. Of course, combining sedatives like additional like alcohol, opioids increases the risk of respiratory depression. But what led to the growth, it was really shown here, is that the benzodiazepines really had a much better safety profile when compared to sedative hypnotic agents like barbiturates, and that has really led to the growth. In terms of how they work, benzodiazepines enhance GABA, which is the inhibitory hormone. And by enhancing those GABA responses, by increasing the frequency of the chloride channel openings of the GABA receptors. And on this receptor, there are 5 subunits. The most common, as you can see here, there's 2 alpha subunits, 2 beta subunits, and 1 gamma subunit, and the benzos kind of bind right in between the alpha and the gamma and the gamma subunit to exert its effect in allowing for GABA to exert its activity, inhibition. So when patients use benzodiazepines chronically, however, there are changes that can occur to the GABA receptors. One, there could be fewer numbers of GABA receptors available. There could be selective changes in the expression of the GABA receptor that can lead to the internalization of the receptor. And it can also enhance these glutamatergic receptors, these receptors that lead to excitation, anxiety, all these things, especially if you stop benzodiazepine use in someone who used it chronically. And most importantly, which I've highlighted in the first bullet here, is that benzodiazepines activate the dopaminergic neuron. They activate dopamine in the ventral tegmental area by really modulating those GABA receptors and by increasing the dopamine in the nucleus accumbens. And that's really why we should think about addiction, why benzos, just like opioids, have high risk of addiction because of their association with increasing the amount of dopamine in the brain. And just like opioid use disorder, patients experience withdrawal. As you can see here listed, there are mild withdrawal symptoms, anxiety, insomnia, for example. You have some moderate withdrawal symptoms, which can include sleep disturbances, irritability, palpitations, and tremor. Then you also have severe withdrawal symptoms such as seizures and psychoses that require immediate medical attention. But just like opioid use disorder, because both of these, we want to really make sure we understand it as a chronic, both of them as chronic relapsing disease, but patients experience protracted withdrawal beyond beyond the acute withdrawal symptoms, the acute withdrawal symptoms usually last for up to 14 days, but the protracted withdrawal symptoms can last for months, if not years. And it's these protracted withdrawal symptoms, which can include irritability, continued anxiety, that lead someone to potential relapse. And perhaps if someone who's also relapsed on opioids can lead to overdose deaths. And just to kind of understand benzodiazepines and the differences and ones that are the most frequently abused and addicting are alprazolam and diazepam. Really the ones that have a faster onset of action or perhaps intermediate onset of action and shorter duration of action. Those that are faster metabolized have higher risk of abuse because their levels are not as consistent as long-acting benzodiazepines like clonazepam. But something about alprazolam and why it's so addictive and why this is really the drug that we focus on in benzos is that it has a lot of unique properties that make it a higher risk for addiction. For one thing, it has a shorter half-life compared to your other benzos, about 8 to 16 hours. It's also a triazolol benzodiazepine. So it has this extra ring structure that perhaps can allow it to bind better to the GABA receptor and really lead to changes in receptor binding affinity. It also has an association with increased release of dopamine compared to the other benzos, and can also lead to more intense withdrawal symptoms that we have listed on the slide there, but also symptoms associated with tachycardia, increased hypertension, for example, because alprazolam also has some alpha-2 adrenergic effects. And by that, we mean that it can, it prevents the catecholamine surge, which can reduce blood pressure. Just like clonidine, for example. Clonidine is often used for this purpose. And then if someone who's been on alprazolam for a long time and you withdraw alprazolam, they can really lead to really high blood pressure and tachycardia, all those particular issues that leads to this catecholamine surge. And of course, alprazolam, compared to other benzos, have higher risk of delirium and psychoses, especially if one is abruptly stopped compared to the other benzos. So what we really think about with benzo use is these adverse effects with long-term use. Reasons why we need to perhaps taper patients: sedation, psychomotor impairment, cognitive impairment that can last for months, if not years, even after stopping the therapy. Their ability to experience emotions and emotional blunting is also something that is commonly observed even after stopping benzos like alprazolam for a long period of time. Especially for older patients as well, you have fractures and falls, and of course, overdose when added to other drugs that lead to sedation. And because a lot of patients, especially those with substance use disorders, have lots of issues with social determinants of health, there is a much higher risk of addiction. So we also want to think about social determinants of health, the treatment of that, helping patients with those aspects of their lives that can, reduce the impacts of long-term use of benzos. Now I want to switch gears and look at the literature in benzodiazepine use, looking at some of the outcomes in patients with opioid use disorder. So I think this is the area where I think it's going to be quite interesting. This study was a retrospective cohort study of 63,000 Massachusetts residents that looked at the association between prescribed benzos, overdose death, and buprenorphine discontinuation. So what they really wanted to find was whether or not taking benzodiazepine, being prescribed a benzodiazepine, had an association with fatal opioid overdose, non-fatal opioid overdose, all-cause mortality, and buprenorphine discussion. As you can see from these Kaplan-Meier curves, is that there is an association increased association with fatal opioid overdoses and mortality with the use of benzos and buprenorphine. However, by being on both, however, led to less discontinuation of buprenorphine. So what the conclusion of this study was that benzodiazepine are associated with harms, but with decreased risk of buprenorphine discontinuation. So we're thinking about treatment retention, and we're thinking about, perhaps in the long term, patients who are on who are taking benzodiazepines and on buprenorphine might have better chances of success in terms of reduction in overdose deaths in the long run because they're maintained on buprenorphine, because the benzodiazepine might be addressing some of the underlying anxiety and depression that might not be treated with the opioid use disorder medication like buprenorphine, but it also really emphasizes the importance of ensuring that we're using the optimal dose of the medication for opioid use disorder to also reduce harms, overdoses with the use of opioids. The next study I want to look at is the case crossover study. So patients were served as their own control, and it looked at the outcome of non-fatal drug-related poisoning. So this was they wanted to look at the association between benzodiazepines and these non-fatal drug poisonings among patients on buprenorphine. What they found was that benzodiazepines by themselves had an increased risk of non-fatal drug-related poisonings, associated with an 88% increase in risk, as you can see in this slide. But taking buprenorphine, although had an increased risk of non-fatal drug-related poisonings compared to buprenorphine by itself, overall, there was a net lower risk of these non-fatal drug-related poisonings when you're taking both benzodiazepines and buprenorphine. So in conclusion, the risk of non-fatal drug-related poisonings associated with benzodiazepines is partially reduced by buprenorphine treatment. And I have on this slide also that high-dose benzodiazepine is associated with increased poisoning compared to low dose. But again, the combination with buprenorphine really had a lower odds risk associated with treatment when compared to patients who are on benzos without the buprenorphine. And also because this again showed the importance of retaining patients on treatment, right? And reducing drug poisonings, that dose reductions may be preferable to abruptly stopping benzodiazepine use. So I also wanted to bring about a study that looked at treatment retention and mortality amongst benzodiazepines and buprenorphine patients. This was a case note review looking at 278 patients in a small general practice in London. And what they wanted to see, they wanted to compare and see amongst patients who are maintained on benzodiazepines, or perhaps taking only occasional benzos or not taking any benzos at all, and what are their effects on treatment retention, in-treatment mortality, and mortality after leaving care. Amongst those patients who were maintained on therapy, they had a much higher treatment retention. In terms of in-treatment mortality, however, those who were given occasional benzodiazepines had lower in-treatment mortality. But what was most interesting was the fact that after leaving care, perhaps they dropped out of treatment, the mortality was highest amongst those who were maintained on benzodiazepines, And the likelihood of them continuing to receive benzodiazepines after they left care was low. So it really emphasized the importance of treatment retention, keeping patients in treatment to really overall be able to address the needs of the overall goal of preventing overdose deaths. Interestingly, in this study, in the maintenance therapy group, the incidence of alcohol dependence, injection, and Hep C was higher, which could have influenced these results. But the results are here that shows that, giving patients benzos, patients who need benzos and on medications for opioid use disorder can really help patients retain in treatment. And that's really what we really want to emphasize, and perhaps has some effects on mortality as well, especially in patients who leave care. And just for some additional studies, in patients with MOUD and looking at maintenance therapy versus gradual reduction. In Weitzman and colleagues, they found that patients who were maintained on clonazepam, how much higher patients refrained from abusing additional benzodiazepines over an entire year in that group versus those who were gradually reduced on clonazepam. And in both groups, patients were on methadone. Elliott and colleagues looked at the difficulty of tapering patients off of diazepam in patients with methadone. In fact, after 6 months, only 10 patients were only able to achieve 10% dose reduction in those who were able to stay in the study. And then in terms of, in the next study, Marimani and colleagues, which is a case series that looked at the feasibility of clonazepam maintenance therapy with methadone and treatment retention, what they found was that, again, treatment retention was higher. And what was also interesting was that the methadone average dose that was in amongst these patients was 190 milligrams, and the Klonopin was about 21 milligrams. So again, it is possible to give benzos with medications for opioid use disorder, but of course we have to think about, the benefits and the risks. So the last part of the presentation I want to talk about is assessment and treatment. So what we need to understand is that with opioid use disorder, we have evidence-based pharmacological treatment for preventing overdose deaths, and that's buprenorphine, methadone, and Vivitrol. But with benzodiazepine use disorder, however, which is also a chronic relapsing disease, there isn't evidence base for the use of pharmacological treatment. As we discussed in those adverse events, there are long-term risks with cognitive impairment that can lead to dementia, higher risk of dementia, psychomotor impairments, falls. All these things really lead to helping to really determine whether or not what should be the best course of action. And in most part, it's about either tapering or tapering down to the lowest effective dose. Because amongst patients who use benzodiazepines chronically, the likelihood of tapering off completely is really low, especially when we consider the mechanism of action that we talked about in the previous slide. One thing that we want to definitely emphasize is that the FDA urges caution that we should not withhold opioid addiction medications from patients taking benzos, and that we really need to, evaluate the benefits and risks of keeping the patients on it, because overall, treatment of this co-occurring conditions is really individualized. It really needs to be individualized in order to, attain the best outcomes for our patients. We also need to be able to distinguish therapeutic versus abuse. And some of the strategies that we should look at in terms of whether someone is seeking benzodiazepines, or they're trying to obtain benzodiazepines for non-medical use. We want to see if they're requesting dose increases frequently, they're running out of medications early, if they're frequently losing or having their medications stolen. All these things can help guide us as to whether or not benzodiazepines are truly indicated for patients who have been using benzos chronically. So when we assess patients, we want to assess for therapeutic use, abuse, and dependence. There is the severity of dependence scale that can be helpful. We want to be able to obtain the urine drug screening, but we also need to understand that by obtaining the urine drug screening that there are some limitations, because your typical tools might not be able to screen for every single benzodiazepine. For example, clonazepam, alprazolam, and lorazepam are typically not found in your typical drug panels because they're not broken down into oxazepam like diazepam would be, for example. So there is the risk of false negatives. So understanding the limitations and understanding how these benzodiazepines are metabolized are really important. Looking at recent and previous benzodiazepine use is also important. How long have they used it for? Have they used it chronically every day, for example? Because that can really help us to understand whether or not one is successful at tapering all the way, or perhaps we need to lower the dose. We need to taper down to the lowest effective dose. The frequency, the amount that they're using, the route of use, whether it's injection or orally, and their relationship with the benzodiazepines. Whether or not that really determines whether the addictive nature, like whether or not their relationship, that they need their benzos in order to live. What is their reason for use? Help with opioid withdrawal, counter stimulant effects, or they're using it therapeutically, and also understanding where they're getting their benzodiazepines from. And through all the assessment, we also need to address the particular harms within our specific patients, especially what we talked about with psychomotive and cognitive impairment, and the withdrawal symptoms that can lead to seizures, increased anxiety, or even perceptual changes here. And we also need to ensure that we conduct both the medical and psychiatric assessment appropriately, especially in those with COPD, those with underlying psychiatric disorder, ensuring that all those conditions are adequately treated as well. And this is just a quick slide to look at the metabolism of benzos. And as I pointed out, that your usual benzodiazepines like diazepam or Librium chlordiazepoxide break down into oxazepam. And then in terms of recommendations for treatment, what we really need to focus on is utilizing a patient-centered stepped care approach. And what we really need to focus is that we need to develop that trust with the patient, ensuring that they understand what are their goals of care so that they're more able to be successful. Even the involvement of family is also really important, providing structure in supporting them in their journey to really get their benzodiazepine use disorder, both their benzo use disorder and their opioid use disorder under control. So when we think about this, if someone comes in with already taking benzos, we want to avoid abrupt discontinuation, which can lead to worsening of substance use disorder and the higher likelihood of relapse. Especially for those who are dependent on benzos, tapering might be the best option. We want to possibly transfer to a long-acting benzo like clonazepam, which can reduce the variation in the drug levels. And also in patients who, especially in patients who, where short-acting benzodiazepines like alprazolam can lead to withdrawal symptoms. We then want to stabilize patients and then taper over months. Tapering over months, maybe even years, because those chronically using over years have really low chances of successfully tapering off. We want to also ensure that the optimal dose of the medications for opioid use disorder are used. Are we treating to the most appropriate dose for their buprenorphine and their or perhaps they're on methadone, for example. And we also, in terms of dependence with adjunct therapy, there really is limited use for them. Carbamazepine and gabapentin have limited use, although they might be beneficial in the protracted withdrawals and perhaps reducing cravings. But the idea here is that most patients, in order to treat their benzo withdrawal, really need the benzo in order to feel relief. So we need to also consider using benzos in a way that reduces risk, increases benefits. And we also must not forget using psychotherapy, cognitive behavioral therapy, and motivational interviewing for many of our patients, and maximize first-line treatment options. If the patients are not on SSRIs, which is the first-line treatment for anxiety and depression, we want to stick with these agents. And if they failed in the past, really understand why did they fail in the past? Did they not use it for a long enough trial? And those are things to consider. And how we would taper benzos, we really want to decrease the withdrawal effects and manage the rebound symptoms and recurrence of disease that could be managed by the benzos. And when you taper the benzos, it's really a slow taper, as we discussed, 25% reduction every 1 to 2 weeks. And that's when you get to that halfway point, you really want to slow down that taper for many patients, maybe even 10 to 25% every 2 to 4 weeks. And the longer, the better the chance for success. And for some patients, it might just be to taper it down to the lowest effective dose, because the lowest effective dose can still reduce a lot of those risks associated with long-term benzodiazepine use, especially in the setting of patients who also have opioid use disorder. And here are some strategies for a more successful taper. We really want to educate on the anxiety and insomnia that, yes, that's going to happen, but it will improve over time. and that if they remain, there are alternative agents and psychotherapy that's important. So we don't just want to focus on medications when we're treating patients with benzodiazepine use disorder. We also really want to highlight these negative outcomes that we've discussed, those adverse effects that can lead to motor vehicle accidents too, and unintentional overdose. And because tapering requires this patient-centered approach, we really need to provide clear instructions and ensure patients are on board. And then through time, they'll develop trust, and really it can definitely help with, the better outcomes for many of these patients. And here is just in summary, some of the treatment strategies. And one of the most important things for benzodiazepine use disorder, patients might need more structure. So contingency management, treatment agreement might be more appropriate in this setting. But we also have to consider harm reduction, which we'll get to in the next slide. And most importantly, we need to document our treatment decisions and our rationale for continuing patients who are indicated for benzodiazepine use in the long run. But when we talk about harm reduction, we need to understand that, if we continue to enforce that you can't take away benzos or take away opioids from patients, right? That leads to harder drugs. Harder and harder drugs continue to infiltrate the illicit drug supply, despite these aggressive interventions that we do to reduce prescribing of controlled substances. So we must keep in mind that that patients are at risk for relapse as part of the disease, and we need to meet the patient where they're at. Street benzodiazepines often contain highly potent synthetic opioids like fentanyl that are unbeknownst to the person using the drug. So if they were abruptly stopped on the benzos, they might turn to, because of the disease, having benzodiazepine use disorder, they can turn to getting, for example, alprazolam on the street, which often is laced with fentanyl. There's also the growth of other tranquilizers to think about, like xylazine, which is prevalent in the Philly region. And we also need to ensure access to Narcan and clean syringes. So in summary, long-term benzodiazepine truly carries serious risks, and there is no evidence-based pharmacological treatment available in those with use disorder. So when we think about treating these patients and ensuring that they have good outcomes, treatment retention in the studies we discussed is a major factor to consider when thinking about managing those with benzodiazepines in those with opioid use disorder when we think of long-term effects. Without retaining in treatment, there are much higher risk of relapse and overdose death, especially in the landscape we're in today. The rate of successfully tapering off benzos in patients with chronic benzo use is low, and so ensuring a patient-centered multidisciplinary approach is essential. Benzo prescribing in patients with substance use history should be done based on the evaluation of benefits and risks with an individualized approach, and we must ensure that our goal is really the focus on prevention of overdose deaths. And of course, documentation of our rationale to justify co-prescribing these medications is warranted in consideration of the risk of abruptly stopping these therapies, which can lead to much worse outcomes. So thank you so much. And in the interest of time, I wanted to introduce Dr. Emily Burkle, who will now present our case presentation.
So thank you so much, Clement, for that great presentation. My name is Emily Burkle, and I'm a physician, an addiction medicine physician at Rutgers University. And I'm going to be talking about a case. This is a 39-year-old pregnant woman. She has opioid use disorder, and she's been on buprenorphine since 2007. She also has anxiety, and she's been on Xanax since 2001. She was receiving 16 milligrams of buprenorphine and 1 milligram of Xanax 3 times per day by her outside physician. But when she followed up with her physician, she told them that she was 18 weeks pregnant, and the physician did not feel comfortable to continue prescribing the medication. She was worried that she would go into withdrawal. She was trying to find a new prescriber, and she did get in touch with our clinic, and we spoke with her over the phone to continue prescribing her medications. So she's been, just a little bit of background, she's been stable in her recovery since starting buprenorphine in 2007, with the exception of one slip that she had in 2010. And she feels that her anxiety is very well controlled on her current dose of Xanax. So we refilled her medications, she followed up with us, and we discussed, issues related to chronic benzodiazepine use and benzodiazepine use during pregnancy. We also discussed how 8 years ago she was pregnant with her first child, and she said that that's when she was switched from Suboxone to buprenorphine monoproduct. And her dose of Xanax was decreased from 1 milligram 4 times per day to 1 milligram 3 times per day during that pregnancy, and she's been on the same medications ever since. She's actually been in psychiatric treatment since the age of 10, psychiatrists, therapists, since the age of 10, ever since her grandmother passed away. And she's been on multiple medications, including Prozac, Paxil, Lexapro, and Zoloft, and she wasn't able to tolerate them due to side effects. She was also prescribed Klonopin in the past for her anxiety, but was switched to Xanax because she would continue to have panic attacks on Klonopin, and found that her anxiety and panic attacks were better controlled on Xanax. So we discussed the risks and benefits and alternatives of maintaining Xanax throughout her pregnancy. At the last visit, she does follow with an OBGYN nearby. Her ultrasounds and her prenatal care visits have been normal so far. And the OBGYN is aware that she is on the medications that she is on. The patient was agreeable to trying to taper Xanax at her last visit. And she seemed to be willing to try other medications. We also discussed, we wouldn't want her to have uncontrolled anxiety during her pregnancy either, or withdrawal. So what she was agreeable to doing the last time we met was to decrease her daily dose of Xanax by 0.5 milligram per week. And if she finds that her anxiety is uncontrolled, to go back to the dose of Xanax at which her anxiety was controlled. So that's a brief summary of this relatively new patient at our clinic.
Thank you very much, Dr. Burkle. Amy, can you put back that that case form with the questions on the bottom? If you could put it back on the screen. Great. So, this is a really interesting case, and I would love for our panelists, Brian and Dr. Baselli, to chime in, or anyone in the network has any particular questions about this case. As we discussed, in this case, however, it appears that the patient is not using benzodiazepines, or is not misusing, I should say, misusing the benzodiazepine. It is controlling their anxiety use disorder for a long time. We do have information in this case that the patient has tried SSRIs, but we're not really sure in terms of what the failure has been with all these different agents, or whether or not they've used it for a long time. So now we have someone who's using alprazolam for a long period of time, and now if the previous prescriber noticed that the patient was pregnant and decided to stop the therapies. Just by stopping the therapies, buprenorphine and the Xanax, we are subjecting the patients to much greater harm, and the baby itself, related to fetal withdrawal, and just the fact that the baby is experiencing that withdrawal. So Dr. Burkle and I had this conversation as to what should we do in terms of the management. And when we look at benzodiazepines in pregnancy, although the old classification was category D, we ought to understand that in terms of teratogenicity and substances, that really alcohol is the only substance that's abused that has really been shown to be teratogenic. In many large studies, benzos have not been shown to have teratogenic effects, although you do see some potential things like left cliff, the lip concerns, right, and other issues. So therefore, the benefit of keeping the patient on, preventing them from withdrawal, really outweighs the risk of being on this therapy. And here, in this case, as Dr. Burkle mentioned, we're lowering the dose as well, which can also help. And this patient is being followed with the OBGYN, regular ultrasounds. So a multidisciplinary approach is truly appropriate in these patients. Brian or Dr. Baselli, did you have any comments you wanted to add about managing benzos in someone like this?
And also, hi.
Dr. Milburn too.
Sorry, I had a hard time getting on, so but I am here. I've been here for a little while.
Yeah, I'm sorry. Dr. Milburn is also addiction medicine specialist at Cooper and has tremendous expertise. So thank you for joining, Dr. Milburn.
Well, I don't know if it's, I just want to, is it all right if I make just some comments also a little bit on just benzos and general with folks with opioid use disorder?
Sure.
Okay. Because I know, I saw most of the presentation, and I guess the one concern I had is, and just, with some of the research you presented, right? The one that shows the improvements in treatment retention, but I feel like it's not really clear how to offset that, right? So I know that I think the one study you had shown, I think the hazard ratio for retention was 0.75, but I think the hazard ratio for overdose was 3, right? I think. So for me, I'm just thinking, that's that's a little bit scary, right? So I guess I would be hard pressed necessarily from that to say, all right, we should start giving benzodiazepines to folks, that because we're looking at treatment retention, but like to me, I'm not sure is that are we doing, is it harm reduction if the rates of overdose go up so much? And then I know that one of the other ones, I think that it was the folks on methadone who were given benzodiazepines at the methadone program, right? But my understanding is that what they had done there, they had been super careful about starting it, right? I think they had done like daily observations until they stopped using other illicit benzodiazepines. And I think they might have still had some daily observation after that. So, because I know that looking at that, I think the overdose rates were very high when they left treatment, but the overdose rates weren't too much higher when they were in treatment. But I think it's important to keep in mind like how closely they were observing people.
Right.
So it seems like it's fairly clear that treatment retention is better. I guess for me, I'm just not 100% sure. Does it offset the risks of the
overdose death.
Of overdose? Yeah. So that would just be my one caution there. I think for the case, and I don't know how other people feel about it, I think for the case, it sounds like this patient's already stable, right? So she's not using anything besides the Xanax. She's not using, she's stable on the buprenorphine. I know for me, and I'm a psychiatrist, just so everyone knows, I hate Xanax. I really hate Xanax for all the reasons, you talked about in your presentation. So, if we could get her on something that was a little longer acting, I would love that. That being said, like, I feel like if somebody's been stable for a long time, I think I have one patient that I have Xanax but he was unstable on it for 4 years before he came to me. He's been stable on it for the 3 years I've been seeing him. So I'm kind of like, do I really want to rock the boat? So, I guess not, my feeling is just based on this case, I probably would continue it. I don't know.
Yeah, thank you so much, Dr. Milburn, for those comments. And I definitely agree with you in terms of the case with the alprazolam if the patient is stable on it, and we want to reduce any risk with withdrawal of the mother, and the patient's doing well, that we should probably keep the patient on alprazolam versus switching to Klonopin, which has some, we have to we transition the patient and potential issues with withdrawal and things like that. But given that in this case, we have a patient who's stable, so I think it's appropriate management. And I also definitely agree with all the other comments you made there regarding treatment retention and whether or not does that offset overdose deaths and things like that. And I guess as Dr. Baselli and I were talking too, is that that's what makes treatment of benzodiazepine use disorder and people with chronic benzo use so difficult, because the fact that they already have, let's say for many of these patients, that most likely they were inappropriately on benzos for such a long period of time. And what are we going to do with them? If we just stop the benzos, they're at much greater risk. But overall, I think the presentation, I think the purpose is not to say, okay, we should definitely prescribe benzos to everyone and benzos because, that we can retain people in treatment. I think the overall thing we should all think about is the idea that we want to ensure we prevent overdose deaths. And as you mentioned, that offsetting is one of those areas that is difficult to really see, just because of all the variations in the studies. And some of those studies, the one where I showed the mortality, it was unadjusted data, a lot of confounders in there as well. And I think it's all the things that we need to think about. So we really need to individualize these cases for many patients. And when I think of treatment retention, I just think if you don't retain the patient in treatment, then perhaps they're not going to be on buprenorphine. If they're not on buprenorphine and they have the opioid use disorder, we have all this fentanyl, these highly potent synthetic opioids. It's truly a benefit versus risk thing, but definitely agree with the comments you made.
Yeah, thanks. And yeah, exactly. So individualized. And the main reason I wanted to bring it up is that for a lot of these folks, they might just be doesn't mean don't do it, but just be super careful. And maybe you just need to watch them a lot.
Yeah. And that's why particularly with benzo use disorders, I think we really should have a more structured approach with a treatment agreement, contingency management, because we don't have evidence-based therapies in terms of pharmacologic therapies to treat this disorder. So a more structured approach might be what's needed for this at this time, to ensure patients are more successful. And in terms of our clinic, I think where those who have had more structure, and specifically with the benzodiazepine use disorder, have had more successes in terms of tapering. If the patient is not willing to, it's not accepting of your plan, that's not going to go well. So really that patient-centered decision making, that step care approach we talked about is so key overall.
I think another thing that we just mentioned and we're thinking about. I'm curious about kind of what the patient's goals are in all of this, and again thinking about her level of motivation might be varied, and there's I'm sure there's probably varying degrees of ambivalence there. So even if she says I want to stay on it completely, I want to get off of it completely, or odds are, like most folks, maybe somewhere in the middle. What level of knowledge and awareness she has about the risks for herself, for the baby, where she falls with all of that, what her purpose of the Xanax use is, kind of what she's getting out of it, how she weighs the pros and cons versus the benefits versus the risks, and kind of looking at all of that. And then I think, and thinking about if we were going to make a change, what ability does she have to make a change as well, right? So what's her level of self-efficacy? Somebody mentioned in the chat about kind of some of the social determinants of health. So what are some of the external factors that would enable her, support her to make a significant medication change like that? So again, I think all of those things are important things to take into account. If let's say she does say, yeah, I want to taper off of this. Does she actually have that ability? Does she have that support? Is it going to work? Does she have the the personal internal capacity to tolerate a benzodiazepine withdrawal? Does she have external supports in her life in terms of housing, relationship support? Again, recognizing that a change like that might not necessarily be easy.
Right.
Yeah, and I think going back to the trust part that you mentioned, does she have the trust with her prescriber that her prescriber is going to support her, that her prescriber is guiding her effectively through this, which is a scary thing, especially because, if you run into a situation where all of a sudden you're seeing a prescriber and the prescriber says, "Oh, you're pregnant? All right, well, guess what? I'm not writing any more prescriptions." That's almost traumatic for folks.
Oh, absolutely. Yeah.
So then I think that develops some of that mistrust and that fear of all of us, of the professionals of the health industry, because the reality is we do things like that. We do make those knee-jerk reactions as a society, as a medical system, in our approach to people with substance use disorders.
Yeah. So by the time a patient like her might come through the door and be seated across from me, she has already faced so many barriers and so many no. By the time I see her, her guard is up so high and she's already anticipating that I'm going to say no and is making her argument for continuing on the medication before we've even had a chance to develop any sort of rapport or relationship. And that's how this happens. I mean, right? Someone's on this habit. Most of the time, it's the story. The story is they've been receiving the medication from one prescriber forever. And there's the relationship. And then it gets ended. And aside from trying to make sure that I get my medication that makes me feel safe, I also lost a safe relationship in there. Most of those things.
Yeah, thank you so much for some of those comments, both Brian and Dr. Baselli. And the other thing I want to talk about, just related to just abruptly stopping these therapies, is the fact that the laws are very complicated, and especially in treating patients with addiction. A lot of our focus is about punishing patients, right? Punishing patients because of the DA, with certain things where if you overprescribe, you might have your license taken away. So I'm sure that prescriber, despite that long relationship, is also trying to ensure that, that he's able to keep their license, have a good relationship with the regulators. So I know Dr. Ovsyannikos, I'm sorry if I'm not pronouncing your name correctly. I don't know if you wanted to unmute yourself. You had various different comments regarding treatment of benzos and opioid use disorder. I don't know if you wanted to comment on that.
My name is Dr. Ovsyannikovska. Dr. O is good enough. I'm a medical director on the Patterson Counseling Center. It's a reasonably big methadone treatment program. We have 500 patients. And we have a little bit different setting when we're talking about that treatment of the patients with addiction, opiate use disorder, that it's not the office-based setting when you are talking to the particular patient one-to-one and creating individual goals of treatment and a pathway to that goals. We have a methadone program. We have people, 10, 15, 20, 100 people staying in one line. And as you understand, they are educating each other and they share their experience. And if you starting allowing to do some person and very individual plan, it's going to be 20 others who are going to come to your office and tell this is my concerns and why this particular patient having this allowed to do the medication and me are not allowed to do that medication. Why you believe I'm more at risk or I'm more at abusing more than anyone else or dependent than anyone. So we have particular problems with this sharing information in between patient, and that comes to the visual treatment, it's getting more complicated. So my main concern is our inconsistency in our regulators that are sending us conflicting messages. As you remember, this CDC guidelines back in 2016 about the opiate and benzo prescription, and that's not recommended, and with all this, the prescribing situation started. And a lot of, at the same time, in the 2016, the FDA put that black box warning on the opiate and benzo prescription. And as you remember, black box warning is the highest level of danger. So at that time, multiple prescribers, including me, started talking to the patients and tried to disengage them from that combination. And apparently it came out of control. That in 2017, the DEA commissioner, Scott Gottlieb, came with a type of the explanation what they meant by that and how we need to approach to that treatment in combination of opiates and benzos, because it's created a problem. And they, again, confirmed in his statement that yes, combination of benzos and opiates is very dangerous, and we still stay on that statement that need to be very, very cautious about that. But on the other hand, we do recognize that probably the combination in opiate use disorder treatment programs and benzodiazepines may have some place. But unfortunately, at that time, 2017, they stated they will add more clarification how we can approach it. But unfortunately, again, till that day, I haven't seen any clarification or any guidance how we can safely prescribe both medication to one particular patient. What's disturbing to me that what they are telling is, yes, you have to prescribe two medications because it was benzodiazepines and methadone or any other opiates, but they also put their recommendation or restriction that they're telling that you have to monitor patient closely for respiratory depression and sedation. And unfortunately, I kind of don't understand how you can do that close monitoring of respiratory depression and sedation for patients who are you're not watching 24/7. And at that time, that becomes this liability issues, yeah? Because in that court, if you're gonna come and your patient gonna die on combination opiates and benzos, the court gonna ask, describe me how you doing this close respiratory depression supervision. And unfortunately, I don't have that answer. So I strongly believe we have to move a little bit to understand that we have to have two pathways. We have to have a pathway on recovery, and we have to have a pathway on harm reduction. And we have to legally support it on that two pathways, because we all know probably half of our patients not looking for recovery. They are pretty happy in the place they are now, and they are looking for the comfort and survival. And they are not looking for the total abstinence or kind of staying on medication-assisted treatment and not to use other drugs. So I strongly believe we have to advocate that we create this harm reduction with the guidelines and standard of care, and again, legal support. Because again, our clients and our patients going to continue the benzo stimulants, opiates during the treatment. But what I want to be sure is that nobody going to take me to court and tell that I knew there is danger and I still continue to prescribe that medication altogether.
Thank you so much for those comments. I know we're very short on time, so I wanted to just, Dr. Milberg, did you have maybe a couple of comments that you have perhaps regarding Dr. O's concerns regarding litigation from your prescribing experiences and your thoughts for like a minute or two, and then we'll end the ECHO presentation.
Yeah, I don't know that I have a ton to add. I mean, I guess there's always a risk, right? And I think that comes back to what you were saying about, having it be so individualized. And you're right. I guess you can't watch them 24/7, right? So, we might have them come in, once a day, and kind of at least try to make sure they're not coming in sedated, checking the drug screens, trying to assess for stability. But yeah, I mean, unfortunately, I think we probably all had, unfortunate outcomes where people have not done well or have died. And I think it always comes down to, risk benefit. And I think, like you had said, just really justifying, in your documentation, why you're doing it, why you think the benefits outweigh the risk. And I guess finding your own comfort level with that. Those are the only thoughts I had.
Yeah, and I think be judicious, document well, especially in the community, involve family, involve anyone that you think could be very helpful for the particular patient case. Because regardless, even if you do follow any guidance, there is still potential for litigation. So I think, as both of you said, the documentation is so important. And just regarding the FDA, I don't think that the FDA will make any statement that will unfortunately help particular cases like this, because they don't necessarily regulate our practice of medicine. So, but they will provide us guidance in terms of risks, benefits, and things like that, and just using that information and individualizing it to the particular patient cases, and communication as well. Because I know you had a question as well regarding if this can be, these risks can be discussed via technology, but it really requires face-to-face communication to be able to, get the best outcomes. So I think that's all it is. The law is very complicated, and advocating, speaking with their colleagues about how these medications work, where are the outcomes, changing, like you mentioned, Dr. O, a harm reduction focus, a focus on reducing harm versus punishing patients, because overall it's a chronic medical disease. And I think that's the next steps that we have to get to. So thank you so much, everyone, for your time. I know we went over by 8 minutes. Dr. Milburn, thank you so much for staying a little over time as well. Appreciate your expertise on this particular topic. And thank you, Dr. O, for all of your comments on this. And of course, thank you, Dr. Burkle, for your wonderful case presentation, which kind of helped us with this engaging discussion that we had. So our next ECHO session will actually be on another case. We'll focus the whole ECHO on complicated cases. It's going to be on Friday, July 30th. So in 3 weeks from 12 p.m. to 1 p.m. Brian Colangelo, our lead clinical social worker, and Dr. Linda Baselli will be presenting in that case. So we hope to see everyone present there at that, which will be a great follow-up to today's discussion and our didactic today. But until then, I hope everyone enjoys their summer and also have a great weekend. Thank you so much for your time.